Hello and welcome to the channel. Well, this video is intended mainly for eye surgeons who are in training, and it is for educational purposes, and I would advise a strong viewer discretion for all the surgical video presentation shown on this channel. Hi, this is Dr. Prashant Shukla, and today I have come up with a very interesting case. She is a 65 years old female patient with chronic diabetes and a high hypermetropic eye. The dioptric power of the intraocular lens in this case was 28.5, and she had a very soft gummy type of a diabetic cataract, and here the cataract was managed using the pre-chopping technique. So let's begin the surgery. By this time one side port has already been made, one more side port has been made. Antechamber is now being stained using Japan blue dye. Well, the red glow was very good considering the excellent light reflex from the Lumira eye microscope. Still, when we are doing pre-chopping, it's good idea to always have a intracapsular staining so that we can identify the rhexis margin more clearly. Dispersive viscoelastic is then instilled into the antechamber and some is just layered over the cornea. Here I am using a 26 gauge bend needle cystitone, and I have raised a flap. The flap is then being everted and moved. Here I am aiming to have at least a 5.5 millimeter capsular opening, because in this case I had plans like I will just tilt and hydroprolapse the nucleus, but somehow in these cases, in these diabetic cases, I have seen that although the nucleus being soft, still the size of the nucleus is appreciably big, and sometimes there is an issue prolapsing these nucleuses through a 5.5 millimeter capsular excess. So I don't intend to have a bigger excess than 5.5. Well, now I am using a micro capsular excess forceps for better control. The excess has been done, and I have got a very decent size capsular opening. A triplanar 2.8 millimeters main phaco incision has been made using a steel keratome. Got a very good tunnel length. A 27 gauge hydrodissection cannula has now been taken for a very extensive corticocleavage hydrodissection, because in these soft cataracts one has to have a very good hydrodissection, and we need to make sure that all the corticocapsular adhesions are being removed. Multiple small fluid waves are passed, the nucleus is stabbed. These diabetic gummy mushy cataracts, well, they pose significant challenge for many surgeons. Even I used to face a lot of problems in my early days, and here I am confirming the mobility of the nucleus using a Sinskey hook through the side port. Well, these cataracts are, the consistency is a bit different from different other cataracts. Here I am using a pre-chopper. Sustainer goes through the side port and a pre-chopper goes through the main incision. Sustainer hooks the equator below the rhexis margin, and both the instruments are brought together for a very nice and clean through and through division of the nucleus. Once we have two heminuclei, then things become really easy. Here I also give a trick to how to prolapse one heminuclei out of the capsular bag. So here we have got a very nice 2 heminuclei with this pre-chopper. This pre-chopper technique is very good for these kind of cataracts, so that we don't have a bowel or any further complications. Now time to phaco. I am taking the phaco handpiece and I will be trying to mobilize one heminuclei out of the capsular bag using this phaco needle. The vacuum being used is about 350, power is about 40, aspiration flow rate is about 35. But the problem here is that the consistency of the nucleus is so gummy and mushy that it's more or less like a crumbly cataract, and I'm not able to hold the cataract at any place, although I tried at multiple places. And here also I have reduced the power to about minimum 15. Still it is very difficult to hold the nuclear pieces, because the moment the phaco needle goes near the piece, they just disappear in front of the phaco handpiece and the nucleus just gets crumbled out. So I plan to come out, put in more viscoelastic, and here is the technique. I am going to embed this SINSKI into the substance, into the wall of the nucleus, heminucleus, and then I am just going to turn it out just like that. So once we embed the SINSKI hook into the wall of the heminuclei, then SINSKI gets embedded in it, and then we have to make a turn in the reverse direction and the heminucleus comes out of the capsular bag. One can always rewind and see how it is done. So when one half of the heminucleus is out, it's now a piece of cake to emulsify these heminucleus, and with the same phaco settings, the heminucleus is now being emulsified. I don't intend to have much of chopping because the consistency of the nucleus is very soft. Still I am doing the quadrant removal in pulse mode because this is a hypermetropic eye and the AC is pretty shallow. I don't want to do much of the maneuvering of the nucleus into the antechamber. I would rather prefer doing things at the iris plane so that we don't damage the corneal endothelium. I am pressing the foot pedal intermittently because I want to deliver the power judiciously and avoid chattering also. I don't want the pieces to run around here and there and go and hit the corneal endothelium. I would just adjust the power settings so that the pieces just move around the phaco tip and do not go and hit the endothelium. Time to replenish the OVD. Here I am trying to get this heminucleus also out of the capsular bag, but somehow it could only be partially be moved because the size of the heminucleus is also big. This is the reason these cataracts do not prolapse out of the capsular bag on hydrodissection, because the size of the nucleus is big, and one should always avoid too much hydrodissection in these kind of diabetic cases, because then due to increase in the pressure one can have a blowout of the posterior capsule. So pre-chopping is a very good technique to manage these kind of cataracts, and yeah, there is some learning curve in these cases, but one gets used to doing it after 2-3 cases. One should always try doing the horizontal chopping, in which the ball tip SINSKI goes below the intercapsular margin at around 6 o'clock if you are operating from superior, and then we can have a chopping. So horizontal chopping, those who are good at doing, they have a limited learning curve. Still, it's a very good technique to master. Now is the time to remove the cortical matter, whatever is left. Some thick epinucleus and some cortical cataract is also there. So that's it. Posterior capsule is very clean, there is no cortical matter left. Now is the time to implant the foldable lens, the planned one. It's a gold spheric hydrophobic single piece monofocal intraocular lens. Dioptric power is 28.5. The bag is filled with viscoelastic, some counter traction from the side port, a very smooth delivery straight into the capsular bag. One haptic goes straight into the capsular bag and the other haptic would be just maneuvered using the same Sinski hook. I normally don't use very sharp choppers or anything like that. I prefer doing it with a Sinski. After implantation, time to remove the viscoelastic, whatever we have pushed in, both behind the intraocular lens and in front. Well, here the vacuum settings is about 450, aspiration flow rate is 45. Now I have switched to a bimanual INA, just irrigating out the viscoelastic both from front and behind. The remaining viscoelastic which is getting stuck to the intraocular lens is now being removed using the same vacuum settings. And we should make sure to remove all the viscoelastic from antechamber and behind the intraocular lens to avoid any postoperative intraocular pressure spikes. There was some iris prolapse through the side port which was then reposited back, some floppy iris kind of a thing. Main port is hydrated. Time to close. Well, do you like the video? Please do like, share and subscribe to my channel and keep following for more updated videos. I'll get more and more interesting cases in near future. Hope this is going to help you in your learning practice. Thank you so much. Have a nice day.